Welcome, everyone. Please come in, take a seat. Welcome. We're going to get started. I will begin with my own introduction and those of my co-panelists. And then, since we have time together, I'd like to hear more from each of you about how you are connected, if you are connected to MOGAD and ADEM. And then we'll go through a presentation where we touch on some of the high-level aspects of both diseases. And fortunately, we have time, so we can entertain questions. We have an opportunity to talk more after the presentation as well. So with that rough outline, I am Teri Schreiner. I am a pediatric neuroimmunologist in Colorado. And ADEM and MOGAD are diagnoses that I am familiar with, and I have many patients with both diagnoses, as well as some of the others that we've already heard about today and are in the other breakout sessions as well. So first, let me turn to my co-panelists and ask them to introduce themselves.
I'm Michael Levy. I am an adult neurologist, but I see kids in my clinic too. I've been taking care of patients with NMO since probably about 2006. We added ADEM, 2011, and MOG in 2017, whatever, but always had this big tent approach, especially with seronegative NMO as well. And thanks.
I'm Grace Gombolay. I'm a pediatric neuroimmunologist. I'm based out of MRI down in Atlanta, Georgia. And I also see patients with these rare neuroinflammatory disorders, including MOG, ADEM, like we're going to talk about today, NMO. Can you not hear me? Okay, is that better? Okay. And just happy to be here to talk more with you guys.
I will proceed next with the slightly more formal part of the presentation, which is talking about acute disseminated encephalomyelitis. I did put up our disclosures. This is commonly done just to put everybody on the same page and know that we do participate in different areas and receive funding from different sponsors. Hopefully this will not color any of the information you received today, and I did not have Dr. Levy, so you can specify any or say you are unconflicted, and that would be great too.
I have lots of conflicts, but they're equally distributed.
Okay. Okay. All right. Wonderful. Okay, so first let's talk about, again, acute disseminated encephalomyelitis. We'll go through this briefly, but this will sort of set the stage then for a subsequent discussion about MOGAD, which is our newer, though not brand new, understanding of some of the cases of ADEM. So ADEM is a diagnosis that in my training, like 10 to 15 years ago, was very common. We saw patients in the hospital who were usually school-aged, not always, but usually in elementary school, were presenting with sometimes confusion, sometimes coma, but certainly a state of being off of their baseline, and then with multifocal other neurologic deficits. And this phenotype, this description of the patient became very familiar, and we would say, okay, we understand this is ADEM. There are diagnostic criteria, and you see some of them here. Encephalopathy is the word that we use to describe being off of your baseline. You're not thinking like yourself, you're not acting like yourself. And in order to meet this diagnosis of ADEM, there can be no fever, because fever itself can contribute to that. What we would see in these patients in the hospital, I will show you an example of in a moment, but a brain MRI that showed areas of inflammation that were oftentimes bilateral, so on both sides, but not symmetric, distributed in different areas, and without a clear edge, a clear border. Here's an example that you see in the top right hand of the screen. Even if you're unfamiliar looking at MRIs, I think you can look and say, oh, there's some white splotchy areas on both sides. Those are the typical lesions, the markers of inflammation that we're seeing with this disorder of ADEM. Now, about 3/4 of patients before they present with this will have a viral illness, and it oftentimes is unremarkable, and it is among the many viral infections that kids will have. But this is an atypical sequelae or uncommon sequelae of that. In addition to the confusion, kids may have headache, they may subsequently develop fever, they may have a stiff neck. Some, I think about 1/3, may have seizures as well. Now, typically, ADEM is monophasic, meaning it happens just once. But it isn't quite that clear, as anything that happens within 3 months of presentation is still technically considered one event, even though it very well does not feel like just one event when there are fluctuations over a 3-month time frame. And then this entity called multiphasic disseminated encephalomyelitis. It was coined to describe episodes of ADEM, this typical presentation of confusion with brain inflammation that were separated by 3 months. Okay, here's some more images just to show these diffuse white matter lesions, again, on both sides of the brain, but not symmetric. Each area here that you see in the white, the sort of bright areas, is inflammation of the parenchyma. Now, yes, ma'am.
Is there any way to remyelate the white matter granules?
So the question is there any way to remyelinate? And I think this ties nicely to your question earlier, which is about recovery. And the answer is yes. Your body has intrinsic reparative capabilities. But a more precise answer to your question about recovery depends a lot on what initiated the attack. So MOGAD, which we'll get to in 1 minute, is an antibody-mediated disorder where we think we know what the antibody does to create the damage. ADEM is a little bit different in that there may be more than one thing contributing to this picture, this clinical description of a child, usually a child, who has this type of inflammatory brain response. And understanding things on the cellular level helps us to say this is the damage that has happened and this is what we can forecast for recovery.
I had insomnia for 4 months before I had my brain relapse.
Oh gosh, insomnia for 4 months. Oh, that sounds awful.
It was awful.
Yeah, okay. Let me pause on further delving into that question, but I know that is a hot topic, recovery in general, so I promise we won't be done with that answer. So the differential diagnosis, the things that can be confused for ADEM, is long. And the top 3 diagnoses you see there, ADEM, we're talking about now, MS, multiple sclerosis, and NMOSD, are all labels that can be given to a disorder that can be caused by the MOG antibody. The other diagnoses that you see there have different pathophysiologies. They come about in a different way, but they can present very similar to ADEM. They can present as ADEM. And so again, sussing out what actually is causing the clinical picture of ADEM helps us to know how to treat it, whether to expect relapses, and what the recovery can be in broad brushstrokes down the line. Now, there are medicines that are used acutely, and we heard about some of them this morning. The first one, steroids, methylprednisolone, also called solumedrol, is sort of a hallmark of treating any brain inflammation. And it is not a gentle or a very specific treatment. I liken it to sort of like the mallet approach. You know, you're taking a big mallet, you're pounding down the inflammation. It's not specific to one part of the inflammatory cascade. It's a very blunt instrument, but it's also very effective at just really calming inflammation quickly. That's typically used. IVIG, intravenous immunoglobulin, can be used. And then we heard also about plasmapheresis or plasma exchange as a means of sort of taking the plasma out, cleansing it of those pro-inflammatory signals, and then allowing the body to recover. So with that, I think I'll transfer over to Dr. Gombolay, who can take us now into MOGAD, unless there are any other questions right now.
Is there an increased risk for MS if you've had ADEM, like later on in life?
So the question is there an increased risk of MS? And I think we could say no, unless that first presentation of ADEM was actually MS. But then we get into kind of a tricky business of looking at the different biomarkers and how did the diagnosis come about, and then we also have the benefit of time that helps us to know whether or not something is relapsing. But in and of itself, it is a different entity than MS.
All right, so I'm going to take over and talk about myelin oligodendrocyte glycoprotein-associated disease, or MOGAD is what it's called for short. And what this is that first let's step back and ask, what is MOG? What is this protein that we're talking about? And so this is actually a picture of a nerve cell. And so this blue circle here is the cell body, and then this yellow area is called the myelin sheath. And so what happens is I think about it where your nerves in your body are just a whole bunch of highways in terms of signaling, electrical signaling that connects to each other. And the myelin is that covering to sort of help the transmission of those signalings better. It's kind of like the covering of these wires of sort of insulating and trying to do that. So MOG is actually a very, very small portion. The MOG protein is a very, very small portion of the myelin. But because it's on the surface, what we think is that it's more exposed and more amenable for the immune system to come in and sort of try to attack it. And so that's where this comes from. So despite it being a very, very small portion of the proteins, because it's exposed, that's where we think it comes from. And one of the things that came up recently that was really important to know is that there is this group of people of the International MOGAD Consensus Criteria. And it's pretty small on this on purpose, but what I would recommend is that if you're not sure if you fit this diagnosis of MOGAD, I'm not going to talk too much about this, but happy to if there's questions about it, because everything that we put together in terms of a diagnosis is not based on a single test. I mean, maybe aquaporin 4 is going to be one exception to that, but generally, when a patient comes in, they have symptoms, you have different MRI or imaging features, and then you look at the MOG testing, and you sort of say, okay, how does everything fit together? Do you fit more like an ADEM picture? Do you fit more of an MS type picture? Do you fit more of a MOGAD picture? And so there's a lot of different nuances to it. But one of the things that the MOGAD consensus criteria talks about is the clear core clinical events features. That's sort of how MOGAD can present. And the other thing to know is that the antibody testing for MOGAD, most people do end up sending it to the Mayo Clinic, which is a cell-based assay. And there's the titer levels help us in terms of the diagnosis. It doesn't help us in terms of predicting treatment response or whether or not you're going to relapse, which I know makes zero sense, right? You think if you have a super high antibody, that means you're going to have more severe disease or more likely relapse, but that's not the case. But what people have found is that you can have neurological symptoms, you can have brain symptoms that are involved, but you have a very, very low positive titer, so that may or may not be MOGAD. And this actually definition keeps evolving as we learn more about what MOGAD is and what MOGAD isn't. So what are the different types that people can have when they have MOGAD? So it is a type of demyelinating disease. So going with that myelin, that covering around the nerve sheet, is that it's affecting the myelin. So you can have things like optic neuritis, where you have inflammation in your optic nerves. We heard some stories about it this morning where you have vision changes, pain with eye movements. Usually what happens is actually color vision will go first before you actually get changes in blurry vision, but people don't realize it until it's more as the disease progresses. It can look like NMOSD, or neuromyelitis optica spectrum disorder. And so it's sort of interesting how the field has evolved from the aquaporin 4 story to now to MOGAD. And now we have the double seronegative that we still have to figure out what that biomarker is. Acute encephalomyelitis, meaning you have brain involvement and spinal cord involvement. And multiple sclerosis-like phenotype, again, when you have a lot of people who look at just a few MRIs here and there, they look at it and they're like, oh, this is clearly MS. But for people who have seen a lot of images for patients with MOGAD and other related disorders, we start to learn this pattern, and it's like, oh, I understand how this could meet the criteria for MS in terms of their diagnostic criteria, but when you look at it, you're like, this does not look like MS whatsoever. And then transverse myelitis, which is going to sort of be an interesting term as we sort of start redefining these diseases, where you have the spinal cord that's involved. And one of the things to mention is that oftentimes in MOGAD, this is also in aquaporin 4 and NMOSD, in the terms of the spinal cord, you have the center part that's more involved, which is what we call the gray matter, or the cell bodies that are involved. And they sometimes can mimic acute flaccid myelitis or AFM. I know we have a different session that's on AFM going on concurrently, but sometimes in the treatment for this is really critical, or knowing what it is, because I've definitely seen cases where someone says, oh, this was AFM, so they just stopped there. They didn't test for MOG, they didn't test for aquaporin 4, and then they're like, oh, they had recurrent AFM, which is not a thing. And so it's just to be aware of that there's lots of overlap in a lot of these diseases as we're trying to learn all of this. And then you can also have what's called a meningoencephalitis, meaning that it looks like a brain infection of sorts, and where they have, people are really confused, they can have really high fevers, they can have neck stiffness, sort of looks like an infection inside their brain, but it turns out it's related to MOG. One of the features that can be helpful, this is not perfect, each person is different, they don't read the textbook, but if you look at the different areas of the brain and the optic nerves that are involved, you can start to get a sense of, oh, is this more likely MOGAD, is it more likely MS, or is it more likely aquaporin 4? So we're going to look at this, and this is looking at, starting in the top left corner here. So this column here is the NMO aquaporin 4 picture. The middle column is going to be the MOG, or MOGAD picture, and on the right is going to be their MS column. So when you first look at the optic nerves, so here we're looking at the eyeballs, or here up in the top, and the red areas are the areas that are affected. So in aquaporin 4, usually that's closer to the back part of the nerve, of the optic nerve, plus what we call the chiasm. So what happens with your optic nerves is they come together and they cross and they make this X. And so that area is usually more affected in aquaporin 4, and it's usually bilateral, meaning both sides are affected. This is in contrast to MOGAD, where usually it's just the front part of the optic nerves that are more likely involved. It can be unilateral, or one side, or it can be both sides affected. And then MS generally is usually affects it one at a time. It doesn't usually come at the same time. And then when you look at the spinal cord, you can have different areas. So in NMO, you can sort of usually affect sort of the upper part of the spinal cord. You can have that central involvement, like I mentioned earlier, that looks like something like AFM or acute flaccid myelitis. You can have other areas involved, more of the outer areas of the spine. And same thing with MOG. So I hope you can sort of see here on the spinal cord image that even though they can have central gray involvement, you can also have the outer parts also involved. But in MOG, generally it's the more lower parts of the spine. Whereas MS, it's sort of smaller lesions, they're shorter areas of the involved, and they're sort of more spotty, meaning that's not all together, it's usually different areas. And then in the brain, basically there's different areas that can be also involved. And then so for example, here in the MS picture in the bottom right, you're going to have these small areas, these smaller lesions that can happen, whereas the aquaporin 4 and the MOG can be different. So here we talk a little bit more about the different imaging features. So for example, what we call long segment transverse myelitis, meaning you have inflammation of the spine, more than 3 levels are involved. Sort of what patients will experience when they have this is going to be things like weakness, numbness. They can have urinary retention where they can't pee. I think one of the panelists talked about that earlier this morning, or constipation where they have trouble with pooping. Again, the MRI shows more than 3 segments, and that's all together, contiguous, meaning all connected together. And then in terms of the in MOGAD, you have more of that lower part of the spine involved. You can have brainstem involvement with this, and so it can mimic things like some people will think about like a cancer or a tumor can look like this. And so what we're looking at here is we're looking at the front. This is the back of the head. Here are the eyeballs right here. Here, oh good, my cursor's showing up. And then what we're seeing here is this increased area white spots right here in the pons, and this is that area inflammation. And when you have that brainstem involvement, you can have different things where your cranial nerves, which are these special nerves that come out of the brain that do different things. You can have ataxia where you have, it's not that you can't walk, you just have really difficult with your balance with walking. You can also have what's called a cortical encephalitis, something that looks like inflammation or something like an infection, but it turns out it's actually related to MOGAD. And again, people come in with fever, headaches, encephalopathy, seizures. Sometimes they can get really, really severe brain swelling to the point where parts of their brain, unfortunately, can get squished. So that can be very severe at times. One thing to know, which I think is interesting, is what happens when you have repeat MRIs. Because usually when we have a patient who comes with an MRI, you have something abnormal, you'll repeat it again 3-6 months later just to see what's going on. And in the MS world, if you have anything new in terms of new brain lesions and things, you start worrying about ongoing disease activity. There's ongoing inflammation, your treatment's not working, all of those things. MOGAD seems to be slightly different. This has been shown in actually a couple of different large cohorts now, where in that first few months, right after the initial attack, it's very dynamic. The MRI, the inflammation is actually quite dynamic. And so and have new lesions was not uncommon, actually, in about 14% of MOGAD patients, but didn't necessarily mean that you were going to have a clinical relapse. So just because you have new lesions on your MRI in MOGAD doesn't necessarily mean you're having a second attack, which is very different from, example, like the MS world. And the other thing I think is interesting, which a lot of you I think have already experienced in your own personal lives, is that the first episode versus the second episode can look very differently. Like I mentioned earlier, MOGAD can present in a whole bunch of different ways, but the second event doesn't necessarily mean it's going to look like the first attack. So this was a study from actually the U.S. network of pediatric MS centers, where they looked at what was the first attack in MOGAD and what did the second attack look like. So for example, in this top column, a lot of patients were looked like ADEM, but they actually had MOGAD, versus optic neuritis, transverse myelitis, versus like an NMOSD looking like picture, versus other vague demyelination or encephalitis where it didn't quite fit in any of those categories, but they had that. And so a good proportion of patients who had ADEM, optic neuritis, transverse myelitis, NMOSD, and or the other things, a good proportion of them were monophasic, because I think there was a question in the room already, what's the relapse risk? And right now we think it's still about 50-50. Unfortunately, we don't have any good biomarkers of predicting who is going to relapse versus not, but there's a lot of interesting research and work looking at how to predict relapse and all of these things. So that's a very important thing. But then the second attack may be something else. So like Dr. Schreiner had talked about earlier, multiphasic ADEM or MDEM as what it's called, ADEM optic neuritis or NMOSD or transverse myelitis. So it's interesting to think about why did the first attack happen? Why does the second attack look different? And also who has a second attack and who doesn't? So one of the things to know is that, and this is important for people to know, and this is one of the things that we just sort of make sure that doctors and physicians and clinicians are aware of, is that when you're sending testing for the MOG and aquaporin 4 antibodies, make sure that you're sending it from the blood or the serum, because it's more sensitive in the serum and CSF. There's a few places that will do CSF-specific MOG testing. The Mayo currently is not offering it on a commercial basis. Excuse me. But CSF aquaporin 4 is sent, can be sent on a commercial basis. And I've definitely seen patients who they'll send the CSF aquaporin 4, they say it's negative, and they say we're done. But it's actually, you really need to send serum testing. And the other thing to note is that it can be positive up to many years after the initial attack. So for people who are having multiple attacks, I'd make sure I resend it at different things. And this is in contrast to other antibody things that can affect the brain and the central nervous system, where few exceptions are in this too. But for the most part, the CSF test is a better test than the cerebral spinal fluid test, or the spinal tap. It's a better test than from the blood, but MOG and aquaporin 4 are going to be those exceptions to that. And then going back to the CSF MOG question. So this is some neuroinformation, and there's ongoing work looking at what's the role of CSF MOG. Does it help? Is it helpful? How does it help in terms of, what patients look like, how they present, their relapse risk, all of those things. But generally, the patients who had CSF MOG antibodies, they all had brain involvement and didn't necessarily have other areas involved. There's one MS patient who actually had positive CSF MOG antibodies. So it goes back to that single test comment that I made earlier. It's not a single test that's going to help you with your diagnosis. You have to take the whole picture in hand. This was a very, very small number, so it's really hard to say. And so this group was suggesting, does the CSF MOG antibody testing predict disability, predict recovery, or poor recovery, or increase relapse risk? But again, this was a very small number, so there's a lot more work that needs to be done before we can do that. Recovery from attacks in MOGAD can be various different ways. And so there's a lot of different things in terms of not only the type of attack that you've had, but also the age also plays a role into that, because there's some discussion about what can help in terms of predicting recovery. So here in this left graph here we're looking at recovery from the distinct onset attack types. The full recovery is here in the whites, good is in this gray, moderate is this like dark pinkish here, and poor is in this super dark red, which is at the top. And generally, patients who have a single eye, single optic neuritis, or if they had an ADEM they generally recovered a bit better than those who had, for example, both eyes involved, or especially if they had spinal cord involvement, they were less likely to recover from it. And then the other thing is that when you're younger, you're more likely to recover than you are from older. And there's a lot of questions of why that is. Is it the repair mechanism? Is that better as we're getting older? Some of those cells, don't work as well. Is that what it is? The other thing is that, especially in ADEM, even though we're calling all of this as demyelination, meaning you have myelin that formed, you have inflammation that attacks it, and then you're affecting the myelin. Why is recovery better in, for example, ADEM or MOGAD compared to MS and aquaporin 4? And there's a lot of questions about that. Is what's actually happening in your brain and the body? Are you actually losing myelin? Because in the MS world especially, you can see it where you have loss of myelin, and that is what, the cells are actually eating it up. Whereas in ADEM, for example, are we just seeing inflammation with extra fluid involved, but as the fluid goes away, that's why, so you're not actually having true injury. And so there's a lot of discussion around that too.
What causes the severity of the relapse? My relapses have always been severe. My left eye completely blind.
Yes.
My right eye completely blind.
Yes.
My brain being affected.
Yes. So that's a very, very good question. I invite my panelists if they have any other comments for that, but we don't have a way to predict right now of the severity, who's going to have a very severe relapse, kind of what we were talking about, or how they're recovering from it. There's a lot of people who are looking into that, though. Other questions? Okay. Yes?
We're in the middle of flu season right now, people taking the COVID shots and that sort of thing. How do the vaccines, particularly at our age, how do the vaccines affect them?
Yeah, so right now, we do recommend, depending on what treatments and stuff you're on, definitely getting all your recommended vaccines is important. There's not really that I know of, let me step back. So we know that there can be potentially vaccines that can trigger inflammation in the body and that can cause symptoms. But generally all of those things are what we call associations, meaning the timing of something happens and then you happen to have something else right around that time. And so they're associated together, but we can't really prove whether or not it caused it, if that makes sense.
I would recommend taking the COVID vaccine and the flu vaccine at the same time. Does that start to correct again?
So there are definitely some patients who feel like they have more symptoms on, coming on when they have multiple vaccines. So if it's one of those things that you feel more comfortable spacing out, I think that's reasonable. The other thing, which I didn't talk about yet, but there's something called pseudo relapses too, or false relapses, where if you've had an attack in the past of anything, even if you're repaired pretty well and you don't have any symptoms, if you get sick, if you have a fever, if you're more tired that day, those old symptoms can come back. They should go away, and they feel like a new attack. They look like a new attack, but they'll go away after the fever and infection goes away. I saw another question. Yes. Hi.
So from my experience, like running support groups and meeting patients, it seems to me like there are a lot of adults who get ADEM who don't recover as well, versus kids who can really bounce back because of neuroplasticity and all of that. But is that been your experience? That last chart seemed to show that ADEM, even in adulthood, recovers better. Is that what that mean?
So as a pediatric neurologist who doesn't see too many adults, I can't make that comparative thing, but I'm curious, Dr. Levy, if that's generally what you see. Do the adults with ADEM recover not as well as the kids with ADEM?
Yeah, that's been my experience too. Adults with ADEM have it much worse than kids with ADEM. But in either case, it takes years to get back to where they were. So, but kids, yeah, generally recover better. And I think a lot of kids at a younger age, when they get symptoms, they could have, if their ADEM is like at 7, then even when they're in high school, they're going to have attention deficit, lots of these other symptoms as well. That's attributable to the ADEM damage they had as a child.
I saw another hand. Oh, yeah, go ahead.
This might be a question that maybe you're not ready to answer, but, with only a certain amount of data over time for MOGAD, is there a notion that, patients who are on pretty good treatment, maybe not 100% successful treatment, could have what they think might be pseudo relapses that may actually be really low-level relapses, and over time, that there may be like a progressive nature to the damage that occurs maybe over 10 years, or maybe their eyesight gets much worse over that time from those low-level relapses. Has anyone been looking into that kind of thing?
Yeah, that's a really good question. There are people looking into that, including, there's something called like steroids in the pocket, meaning that where the physicians will get, yes, exactly. Dr. Chen that's his point, where, patients that will, physicians will give patients a steroids prescription. So as soon as they feel anything, it may or may not be a pseudo relapse. They'll go ahead and give the steroids right away to hopefully prevent that. And it's one of those things where, there is ongoing studies looking at ongoing, involvement. Like, I think the optic nerve is a beautiful example of that, because we have special ultrasounds in the back of the eye called optical coherence tomographies, where you can actually start tracking different levels of different areas of the back of the eye of what's being involved, and sort of monitoring, are those layers getting thinner, or is there ongoing injury or damage that we're seeing that we may not detect clinically, or on an MRI we can see in other ways. So.
But just one comment on that is that, if your RNFL has bottomed out, like mine is way below what it should be, and it's not going to change with a relapse very much or at all, how does that OCT lend to that, or do they have to completely rely on field vision tests and things like that?
Yeah, I think that's where we have to put everything together, what the patient's reporting, because our tests are just as good as they can be, right, including the OCTs, like you mentioned. They do bottom out, meaning that there's a certain level at which it's really hard to detect any change. That's why you have to take everything together. The exam, the physician's exam, and then all the testing that we have. Unfortunately, our MRIs are not perfect either, and if you can't get contrast, that makes it even harder to know what's happening. So, yeah, I'm so sorry. I think your question, and then I'll take you. So.
Well, it's really a comment. In our case, the understanding that it was MOG was delayed a little bit. The comment that we got at the time was it was a young person's disease. It wasn't supposed to get after somebody over 70. So it kind of slowed down. They kept trying to put us in the MS bucket, and finally realized
Oh, that's quite unfortunate. I took the slide out. I should have put it back in. But there's a really nice age distribution graph in terms of MOGAD. And there's clearly patients who are older. They fit the more the NMOSD-ish phenotype, whereas the younger patients fit the ADEM. But it shows that
Yeah, it was
older
a
patients.
discussion in our group, listening to them talk to each other. It's kind of like, well, she's too old for that.
Yeah. What's the oldest patient you diagnosed with MOGAD, Dr. Levy?
Oldest is 75 so far. 75, wow. But aquaporin 4 NMO, 91 years old in the hospital.
Wow.
So, not the same.
Yeah. And then, sorry, your question. Yeah.
I was just going to make a comment really quick that, when you were talking about in terms of the pseudo relapse,
Mhm.
the possible progression, one of the things that I heard recently from another doctor was, again, the importance of looking at both, again, the imaging and the imaging itself, and that's why it's so important that we do have a biomarker now, and so we can look at titers that can help kind of determine, whether or not this is a potentially progressive thing versus a pseudo relapse. And again, the steroids in my pocket is very much a real thing, and I think just about any of us can attest to the efficacy of that and how important that is. But no, I was just going to say that I think that that's why there's a big reason that we need to have both the imaging and the biomarkers, and they have to work together.
Yes, exactly. That's exactly correct. Yes.
Okay, so mine's kind of piggybacking on that with the pseudo relapse. So at the beginning, when everything is new and you first have like ON, but then you get TM, they're not really the same, and you don't really know what to expect. After the initial TM, I was on a lot of steroids, like 100 a day, but I kept having, so that's where I would get confused. Is this a pseudo issue or is this new? Because I would get a new symptom, but was it being masked because I was taking preventative treatment and I was taking plasma exchange, but I was still getting new symptoms. So I think that part, for me, the disease was new, but then I felt like I was, I didn't know what was legitimate and new something. Was I having an attack or was it a pseudo? So that would be my question. What about the people that are, all the treatment is new and you're on a steroid daily? How do you determine, and what would be your plan of action for people like that?
Yeah. You're looking at Dr. Levy, so I'm going to let Dr. Levy answer that question.
Well, I'll tell you, I absolutely hate prednisone.
I did too.
I have like 160 MOG patients, and a few of them are on prednisone, and all the phone calls come from them.
Okay.
They're having symptoms that fluctuate. I try to get them off of prednisone as quickly as possible. I hate the steroids in a pocket idea, because you take a bunch of steroids, you feel great for 2 days, and then you come off and you call me again. And it's always up and down and up and down. I'd much rather people go on a preventive medication, if that's what they're using, on a stable dose, and then just, stay off of prednisone as much as possible. That's been my...
I am since February, so that's good.
Great.
But it took a long time.
I have a question about that. Okay, so for those of us where the only treatment that we were given was steroids and are now steroid dependent, how do you address that? And again, because now I have secondary adrenal insufficiency. And also, how much do you think, I don't look like somebody that's on steroids, but I still am. So again, how much do you think that the drug delivery system impacts the long-term use of the steroids?
I would rely on some of my endocrinology colleagues to help you
Okay.
come off. What happens when you use steroids for a long time is that your adrenal glands don't need to make steroids anymore, the natural steroids, so they just shut down. So when you bring people off of steroids who've been on them for a long time, you got to wait for the adrenal glands to wake back up and make their own natural steroids. And in some people, it just never turns back on, which means in order to maintain your own blood pressure, your own body chemistry, salts and everything, you have to give them a little bit of steroids on a regular basis from now on. I don't know what long-term strategies there are these days to get people off of steroids, But that mark usually comes after about 3 years of being on steroids. And so we really, really try to get people off as soon as possible, as best as we can. And I do feel like if you overlap steroids with something like IVIG or tocilizumab or something like that, you have a better chance of being able to come off of prednisone without relapsing.
I was just wondering particularly, specifically though, about the drug delivery system and how much that's been investigated, at least in terms of this space, the neuroimmunology space, as opposed to just the neuroimmunology space.
What do you mean the drug delivery
Like in
system?
terms of literally IV steroids versus oral steroids.
Oh, yeah. Yeah, IV steroids don't have as many side effects.
Yes.
But the idea is this: so you're going to take like maybe a 1,000 milligram dose at the beginning of the month, and then you don't take anything for the rest of the month. So if you average it out over 30 days, it's about 33 milligrams a day. You could do that, or you could take 33 milligrams every day. It kind of has the same effect, but there are many, many fewer side effects if you do intravenous. I don't know why. There are also fewer side effects if you do, instead of 20 milligrams a day, if you do 30 and then 10 the next day, and 30 the next day, and then 10 the next day. There are also fewer side effects with that. So there's still mysteries about steroid dosing that we need to explore, but I just try to avoid them as much as possible.
I saw a hand up in the back, so, yeah.
Yeah, I was just going to bring up the steroid and pocket thing here. Not really these thoughts, but me too.
Is it true that your body produces 5 milligrams of prednisone on its own each day?
That's approximately in an adult, yeah, somewhere between 5 and 10. Yeah, yeah. Okay. Yes.
Some MRIs, like with MOG and ADEM and stuff, after it's over, a year or so later, their MRIs are clear, but some aren't. So is that normal to have?
Yeah, so I've seen a wide spectrum where, and that's in the different conditions. In MOGAD and ADEM, more likely to have those lesions go away. I said more likely, it's not true across the board. Whereas MS, those lesions are more likely to persist, meaning that you'll still see them even if they're a year or two out from them. I've definitely seen the lesions or those white spots slowly go away over time, meaning that we see it and then over the next few years. And so it goes back into that, is there a repair of that myelin? What's going on with that? Why is the MRI not picking it up as much? Lots of questions with that.
So 5 years later?
I've seen it many years later where there was a spot there, and then many years later we're not seeing it again. But in general, MOGAD and ADEM, generally most, if not all, the lesions go away. You can see a little bit left, like kind of like a scar. Whereas MS, you're more likely to see those lesions stay around. I think I saw more questions. Yes.
I have a question. I was misdiagnosed with MS prior to my MOG diagnosis.
Mm-hmm.
I was wondering, because I know so many people were diagnosed with NMOSD and then reclassified as MOG. Is that going to happen to us?
That's a good question. Well, I think the thing is that there's a few things. It goes back to the philosophy of what is a diagnosis, right? Diagnosis gives you an idea. A, you're naming something, the symptoms and everything this patient's experiencing, so you name it, right? B, it helps you define what's the treatment specifically for it. And for many, many years, there are patients who have, now we know, MOGAD, who look like the aquaportin for NMOSD. They fit that NMOSD criteria. Now we're realizing those diseases actually behave a little differently from each other, right? The aquaportin 4 versus the, I know people hate the term, double seronegative NMOSD versus the MOGAD. So I think now we're realizing MOGAD is sort of its own entity of itself, because now we know the treatments are slightly different compared to MOGAD. Obviously, or NMOSD, excuse me. Obviously, there's some overlap with the treatments, including with MS, right? I think rituximab is probably a good or example of that, but generally, go ahead.
What about, like, some of my friends had lost their vision because they were on MS meds, and then they were diagnosed with MOG. Can that happen as well? I mean, like, what if all of a sudden...
Yeah, so what's confusing is that if you look at a lot of the older literature looking at MS versus MOG and MOGAD and all of that, there's so much overlap that people were still trying to define it, which I think why it was very important for this international MOGAD consensus criteria to come out to really help define, okay, this is what MOGAD looks like. Because if you look at some of the older papers, after MOG became more commercially available for testing, you'll see some old, like, oh, patients with MS, like 5% of MS patients can have MOG titers, but that doesn't make sense because MOGAD is a different disease from MS. And then you'll see these other papers saying, oh, certain MS medications can trigger an MS flare or relapse, so you shouldn't use those. And we know that's very true for the aquaporin 4 literature, all the papers on aquaporin 4 studies, but in MOGAD. So that's what makes this very confusing, because there are patients who can sort of, like I said earlier, fit the criteria for MS, but when I look at it, I'm like, that's not an MS patient. That looks more like MOGAD. I saw a couple more hands. Okay, go ahead.
Yeah, I was wondering about if there are studies looking at like the effects of steroids and the side effects that they can cause in patients with MOG, in MOG specifically, because there are friends of mine, one might be in this room, who's having symptoms that could be TM, where it's like skin sensitivity or pain or something which can also come with steroids, either the acute, high dose, or long-term chronic. So has that been looked at by people who have recently been on steroids and came off?
Yeah, so that actually leads me to, let's see. So this is the one paper that looks at relapses related to steroid wean. It doesn't quite answer your question about side effects. It's interesting. So one of these MOGAD conferences, like the one in Boston, it was really interesting to hear different people's perspectives on MOGAD, because it was an international conference. There were people, clinicians, researchers from around the world who came to this. So it's very interesting hearing how different people in different countries around the world, how they treat MOGAD. You have certain groups who are very strong proponents for put patients on steroids for many months, whereas you have other people who are strong proponents for steroids are terrible, don't put patients on steroids for very long. But I also think it's about access, unfortunately, in certain countries it's really hard to get, for example, IVIG or tocilizumab, and sometimes all you have is steroids. So there's a lot of things around that. I don't know of anybody in particular who's looking at steroid side effects in MOGAD, but I don't see why someone isn't looking at that. I don't know anyone specifically, but it would be a straightforward study to do.
I think that's a great project for the sRNA to survey. And Jim, no matter what your title, what your disease name will be, you're always welcome to the sRNA. They'll take you in. Don't worry.
I actually, the way I met Dr. Levy was I relapsed 12 times became steroid dependent with optic. It was getting so bad, the side effects. I see Dr. Chen in Mayo Clinic, and he kept telling me about this trial that's coming up, this trial. I kept relapsing, and I was on 65,000 milligrams in like an 18-month period. But, he rushed me into the trial, and I did relapse. I hate to say this, sorry right now, at the beginning of the trial when I was in the Lyme days, because they weaned me very quickly. And I know that's a big thing. In 2 weeks I was weaned and I relapsed. Then it was determined it was relapse. They put me on the drug. I just want everyone to know this. And again, because it's a trial, they wean you again in 2 weeks, which I was absolutely panicked. So I had 2 weeks of this drug in me, I think, at the time, or maybe a little more, and I did not relapse, which I think is really interesting, that all these relapses we have when you're, getting off prednisone, here it was just 1-2 weeks of this new drug, and a 2-week wean after all this prednisone, and I have not relapsed now in 2 years on it, so I think it's everybody, and it's all thanks in part, partially to that man up there.
Group effort, Jim.
All right, I do have a few more slides, but I want to give time for questions, and there's some important points that were brought up earlier. I think fatigue is one of those things that doesn't get talked about as much in MOGAD or in ADEM, but it's something that a lot of, like I said, I see pediatric patients, I see children. fatigue is a really common thing that they even bring up to me. It's something that's talked a lot about in the MS world. But I was just curious for the panelists, how do you counsel your families and patients on fatigue, and what are some strategies that you recommend for them?
Well, I wish I had the cure to fatigue. It is incapacitating in so many ways. And I think it exists across the spectrum of demyelinating disorders. And it's frustrating because you can't see it, right? You can't see a weak arm or, anything that physically gives a clue that you are exhausted. There is no juice left. So I wish I had the cure for that. Some of the techniques that we talk about are energy conservation, so pacing yourself, sleep, making sure that sleep at night is restorative. If you're not sleeping well and you've got fatigue from your disorder, whatever it may be, things are going to be worse. If we can improve the sleep, maybe it's 10% better during the day, but that's 10% that is functionally important. We talk about exercise because although exercise just can wipe you out in the short term, it is one of the things that can build your endurance and your ability to overcome fatigue over time. There are medicines that I will occasionally use for fatigue, and I think somebody pointed out, having tried stimulants, but seeing the negative sequelae of that. It's not my favorite way to treat fatigue, either because of adverse reactions to the medicine itself, or because it's something that you can become reliant on, and it doesn't actually solve the problem. It just kind of pushes you through it. We talk about things like diet. Again, is eating 5 servings of vegetables a day going to make your fatigue go away? No. Can it make it 5% better? Maybe. Hydration is important. So all of these things play a role in trying to overcome this, but I don't want to oversell any of them because it is really a hard thing to treat and to live with.
The only thing I would add is that a lot of medications can cause fatigue, like muscle spasm medications and things like that. So trying to minimize those if you can. Even gabapentin is tiring for a lot of people. So minimizing the amount of medications you're taking.
Do you have other questions? Yeah, go
I
ahead.
have a comment, because I'm actually doing a panel on fatigue tomorrow with Dr. Malbach. And, I have a lot of experience with fatigue. It was my onset to the disease, really. I had a 2-year bout of debilitating fatigue. And the one thing that got me through the day was to time my being awake time. So I'd get up, I'd be awake for a few hours, and I was allowed at my job to have a couch in my office, somewhere I could go, and I would do a power nap. I would not fall asleep, but I would lay there and rest very heavily for 20, 30 minutes, maybe even an hour if I needed to. That got me at least good enough to go through another 3 hours. And so I jumped from my day from 3 hours nap, 3 hours nap. And I had to get rid of any substance like caffeine, alcohol. I had to eat perfectly, and I had to sleep perfectly. And so that's how I managed to do it.
I'm staying up till midnight, Julie.
Yeah, well, now it's a different story, but I mean, if I had to pass on any advice to anyone who's dealing with fatigue, since I had 2 years to figure it out, and nobody would give me any medicine, I didn't have a diagnosis, that's how I did it. And it did work, and it did help.
Other questions? Yes, go ahead.
I'm curious to know, what do we know, I can use teacher voice, but what do we know about the reason why fatigue is so prevalent? What has been explored? I know that it's a little bit harder to quantify. We can't hook someone up I always joke that I wish I could take my son to AutoZone and like plug him into the thing. And they're like, oh, looks like part 17 has got to be replaced. You know, like that would be so much easier. But, you know, like I feel like for a patient for whom 98, really 100% of his symptoms are invisible. And I sometimes wonder if, like, the difficulty measuring those things that are not as visible, where you're relying on self-report, he can't accurately self-report. It's been his norm since he was 7, and he has cognitive issues that are impairing his ability to self-monitor and report. You know, so like I understand that there are things that hinder the ability of science to address these things, but they're very real. And so I'm curious what work is being done or what ideas there might be to ensure that we're continuing to push on these, I mean, like truly life-altering things that, you know, the group of us who have emerging adulthood kind of kiddos, it's like my son would tell you he's going to live in a tiny home in my backyard. And I think that's likely maybe our reality, you know, and so like, but we don't know. So like what can we do? What science is being done to explore how we can overcome these fatigue issues or the cognitive functioning pieces that are sort of more invisible, you know, are things I just was curious about. It's sort of like we tried all those things. It predates all the meds, you know, like we've done all the sleep hygiene, you know, like at some point as a parent, like I think you just kind of want to like roll your eyes whenever people tell you the same thing. Like I get it. And also like, and what else might science be able to bring us?
Is Bardia still sitting in front of you? There he is. Hand the mic over to Bardia, because he's going to tell us everything he knows about fatigue.
All right, as Julie said, we are going to have a session about this tomorrow. You brought up great questions, and we don't have good answers. I think, again, getting back to MS fatigue, so MS is a field that's probably decades in front of rare neuroimmune disorders, and only maybe in the past 10 years, the field is paying more attention to these invisible symptoms. So hopefully with the help of, you know, groups like Siegel and other funding mechanisms, so we could pay attention, we could really study these invisible symptoms would be great. So most of the attention is paid towards prevention of attacks and relapses, and for good reasons. But as you said, many patients, if not majority, but a very good proportion of patients deal with these invisible symptoms that affect their quality of life. And that's actually the case with MS. As you may know, fatigue is considered the most common symptom of MS, and people have done research about it that people who have MS prefer less fatigue and they are okay with kind of exchanging it with more relapses, which is kind of sounds crazy, but just again, I think we need more research about measurement of fatigue in these rare neuroimmune disorders, about the markers that are associated with this condition, again, not necessarily causal, but at least association, and definitely more treatment trials. There have been a lot of treatment trials in MS. Mostly in the past 15 years, we are learning a bit more slowly, but can we translate what we learned from MS to these other rare neuroimmune disorders? I'm not sure about that. That's the best we have for now, but to improve the field, I think we need more research. We need good measurements. We need more attention first. That's number one, to pay attention to invisible symptoms. Second, paying attention to ways to measure these symptoms. Third, doing clinical trials of different interventions. As we talked about, exercise has been tested in MS with good results. Cognitive behavioral therapy, Julie mentioned some of the techniques that are part of cognitive behavioral therapy has been tested in MS with good results. Medication have been tested in MS with not very good results. So at least if we could try the same thing for people with MOGAD, myelitis, NMO, that would be great. Again, more advocacy from patients and family members like you.
Last question.
Please.
Okay, just briefly, I know we've discussed fatigue in this particular group, but if you were to rank fatigue as self-reported, which disease seems to self-report fatigue the most and cognitive disability?
If you are comparing MS and rare neuroimmune disorder, there have been a couple of studies comparing MS and patients with NMO, and it seems that people with MS have a bit higher self-reported fatigue compared to NMO patients. Again, the studies were small, and getting to nitty-gritty, there was no statistically difference between the levels, but numerically, in at least 2 studies that I recently reviewed, fatigue in MS was more severe on average. Again, I have not looked at studies that tested cognitive abilities comparing MS and rare neuroimmune disorders. Again, that's one of the invisible symptoms that can cause a lot of disability and lowered quality of life. So, again, more studies.
What about rashes?
Um,
Start getting hard bumps, little bumps all over your body.
so.
If you scratch them, they can get big to the size of a kid.
So neuroimmune disorders, as the name implies, affect the central nervous system. So they should not directly cause rashes. However, you can think factors associated with the diseases, such as steroid, chronic steroid use, causing skin atrophy and blood vessel fragility, maybe causing rashes, or decrease in activity and ambulation that can cause edema in the legs, edema in dependent areas of the body, skin breakdown, and those kind of things. But the diseases themselves, they only affect the central nervous system, brain, spinal cord, and the optic nerve, and they should not directly affect skin or other tissues in the body.
So maybe it'd be nutrition that I should check into.
Absolutely, nutrition, medication side effect.
Just to touch upon that, I've had now 2 patients now recently who had new psoriasis. Actually, they had a family history of psoriasis, but they're on rituximab or CD20. One happened to be MS, one is an NMOSD patient, but they had new psoriasis that was probably unmasked by being on the CD20. So,
Well, don't get us started on that. I don't know if there's anyone in this room that hasn't had that happen.
Thank you. I know there was a slide on treatment options. I kind of wanted to talk about the financial side of that. I've been on IVIG for a couple of years, and I know that Dr. Levy's published research that it's probably one of the more effective treatments or preventatives. Yeah, it's not covered by insurances. So it's kind of a tough pill to swallow to look at like my out-of-pocket maximum as like a guarantee of what I'm going to have to pay for essentially something that I couldn't control. I know that there's treatments and trials, but I'm just curious. I know IVIG's been around for a long time, and obviously MOG just got its new insurance code. I guess what's being done there?
If I had $1 for every time I fight with an insurance company about IVIG for MOGAD, I'd be wealthy. It's so frustrating. So first of all, I just want to reflect your pain and understand that is very, very expensive. Part of what drives us to do research is to conquer these real-world difficulties that patients have, like getting a medicine that is important to stabilize the disease and providing more and more evidence for it to subsequently, hopefully, make the process easier. That being said, we do research to find out, is in fact IVIG the best? And are there other things that would help as well? And so I think we're in a space right now with MOGAD where we have learned so much since 2017. I mean, oh my goodness, so much. But there is still so much left to know and to try and do better. And one of those realms is treatment. And so I don't know if you want to talk about your work in clinical trials or anything else, but
I'll say about IVIG, so far we only have observational studies, meaning we would go sit around, have a drink and say, well, what's been your experience? Put all the data together and say, okay, this is what we find. But that's not really scientific. It's not really saying we compared this versus this. We were all blinded. Nobody knew who was taking what. To do really good science takes a lot of effort and a lot of money, and the folks behind you are doing that. And that's really what you want to depend on ultimately. Otherwise, you're just using our collective experience, which is helpful. But it's not like you could take that to the bank and say, you should be paying, how much does it cost you? Probably like $300,000 a year, right, for IVIG, something like that?
Mine's about $35,000 every treatment. So
$35,000 a treatment. So it's hard to go to insurance companies and say, well, Dr. Levy said this.
No, that's not what I'm saying, obviously.
Yeah, but that's what we do. We call them and we say, this has been our experience. Here's some studies to support it. Sometimes they approve, sometimes they don't. I'd say I'm about 60%. I don't know.
similar. Yeah.
So, if I just want to give an opinion on how I deal with that, with insurance, because I'm the nurse and I do this, I fight this all the time, especially IVIG with MOGAD. I do two things. Number one is I make sure that if there's a different brand you can use that has a bigger persistence program, because there are vast differences in IVIG. The other thing I'll tell you that I've done, and it's worked 3 out of the 4 times, is when I've fought with insurance and they keep saying no, a lot of times it's experimental. I find the president of the insurance company in my state, and I'm not kidding you, within about 45 minutes, I have some response from them that leads me to the next person that can help me get it done. Because most of the time they are saying it's experimental, but when you put a real story behind it, right, it makes the president go, huh, I probably should do something about that. And I'm not saying it works every time, but it's worked 3 of the 4 times I've had to do it. So I just go to the top, because the people that are doing that insurance, they don't understand. They're not, a lot of times I feel like they're not even reading our clinical information. They don't know what they're doing. So that's just that's how I handle it.
I've also had state senators intervene, and that seems to work. I don't know who they're calling. I don't know who the state senators are calling, but things happen.
I just have one more comment. On the MOG Project website, and actually on the SRNA, there is space for help in getting insurance coverage for, or at least letters, templates, and things like that, and information about what to do. We have a letter template for appeal that Michael Levy was kind enough to, and he may not remember, he's looking at me like I don't remember doing this, helped us create. And the other thing is, I think there's help coming down the road, and there's the option of subcutaneous IG for some, which can be, for me it's $14,000 a month, but it's less. And there also, I think I can say this, is that there is a clinical trial possibly, right? So that will come down the line, and I think that'll change things drastically.
Once it's approved, FDA approved, then you're done. Like that, then it's pretty easy to get insurance coverage.
Dr. Chen wrote a paper, and he was trying to get IVIG before
Yes, so we.
trial for me, and he could not get. I have great insurance. Could not get them to approve it. He got a final denial, and on his own, he took a paper he wrote on the efficacy of IVIG and MOG, and just sent it to my insurance, and they approved it. Actually, finally. So,
Right, and they're in that section on our website. Yeah.
we have it on our website.
Yeah, it's in that section on our website. There are the 3 papers that you want to submit when you, with that appeal when you get it. And, maybe down the line, I mean, after this, these clinical trials hash through, we'll all have a lot better time getting treatment. So it's sort of what.
If someone's currently taking subcutaneous IG, will they qualify for the clinical trial? You have to have relapsed with probably. I don't
Any other questions? We've got about 3 minutes left.
So we're still pretty new to all of this, 2 years. My daughter was diagnosed at 17, she's 19 now, double seronegative NMOSD, but she presents herself more as MOG. The more I hear, I'm like, oh, maybe it is NMO. Oh, wait, maybe it is MOG. But, you know, it's very confusing. I'm also confused, is a relapse, does that mean your disease is not under control? Or, I mean, is that correct? That's correct. Okay. So she's gone, it's usually a year in between relapses. April to April, no optic neuritis. Now November to October, no optic neuritis. Now optic neuritis, and that's on CellCept and IVIG. So does that mean a drug has failed? Does that mean we need to increase it? It's all very confusing.
Yeah, so generally if a patient relapses, there's usually some time frames that we will give. They're kind of arbitrary time windows. Like we talked about the ADEM, everything within that 3-month time frame. For MS and MOGAD, we're saying it was within 1 month. But again, I've had patients who had a true new relapse within 2 weeks of their initial onset. And I'm like, and it was severe enough. I was like, I'm going to call this a relapse, even if it wasn't that definition. But yeah. If you have a relapse on treatment, that means your treatment isn't working, and so either the dosage needs to be changed or you have to switch the treatments in of itself. So.
And really no studies for seronegative, right?
In terms of clinical trials specifically, no, not specifically, but we do try other treatments. So I didn't talk about it in the slide, but there's other treatments that we do consider in MOGAD for patients who fail the traditional things. So IVIG is a common one if you can get it. I know it's super expensive, but it does work pretty well. CellCept or mycophenolate mofetil is also a common one that seems to work. People tried rituximab and MOGAD. Doesn't seem to work as well in MOGAD as it does for aquaporin for NMOSD. Tocilizumab is another one that people will try, whether it's NMOSD or in MOGAD. So that would be another option too. So.
Or vice versa, and you were taking that medication, could that hurt you? Like someone who has MS and was taking...
I'm sorry, can you repeat that question?
So if she is seronegative, so if she actually had MOG and they were giving her medication that works better for NMOSD, could that hurt her? Could that cause her lifelong deficits?
So that's unfortunately a risk right now that we don't know. We don't know what treatment works. We say, oh, this treatment works for most people, but we don't know if it's going to work for you personally. So we trial what we think is the safest and efficacious treatment. I can't answer that, unfortunately. It's one of those things where, you know, if you're on something and you're having more relapses, I would consider switching to something else versus changing the dosages because that's not working.
Like, if her daughter went on rituximab, would that potentially cause harm if she doesn't actually have NMOSD?
It depends on what's causing her underlying things, which sounds like could be seronegative NMOSD. It's hard for me to comment because I don't know all the particular details.
ADEM to begin with, misdiagnosed with MS, and with ADEM, and then optic neuritis multiple times. And then now they're saying NMOSD, double seronegative, presents herself as MOG. But then like the spinal, the lesions in the spine, hers have been at the top, not at the bottom.
Mm-hmm. So that's a really...
It's just like she's both, but she's not either one.
Yes.
You know?
Yeah, we definitely have unfortunately, some patients who do fall in that bucket. And again, I can't comment on your particular situation because I don't know all the details, but in general, for seronegative NMOSD, rituximab can work for patients. So.